I'm pleased to welcome today our experts, Dr. Jory Harden and Dr. Kari Savage, to answer your questions from the breakout session on cutaneous T-cell lymphoma and peripheral lymphoma. As a reminder to our audience members, please type your questions into the Q&A box in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. I'll direct the questions in a roundtable format, making sure each presenter has the opportunity to answer a question. If there is a question that comes in from a specific subtype, then I'll ask the doctor who participated in the specific breakout session. Let's check the Q&A. So the first question that I can see is, does having a higher stage of cutaneous T-cell lymphoma lead to a worse prognosis? I think Dr. Jory can answer this question, please.
I want to just clarify, the question is, does having a prior stage of cutaneous lymphoma, are those?
Higher stage of cutaneous T-cell lymphoma lead to worse prognosis.
Thanks for the question. So is
it possible for you to put the question in the chat so everyone can see it, because it's a little bit hard to hear you, so that everyone can see? Yeah,
sure. Yeah, definitely.
Let me interrupt and just
let me pull the question.
It's very hard.
And while you're doing that, I'll answer the question. So the question is, does having a higher stage of cutaneous T-cell lymphoma portend a worse prognosis? Just to remind you all, the way that we stage cutaneous lymphoma is based on the tumor stage, which is the skin involvement. And skin involvement is staged based on body surface area of involvement. So the T1 stage is less than 10% body surface area, and T2 is more than 10%. T3 is patients who are presenting with tumors, even if they don't have a 10% body surface area. And T4 is erythroderma. And yes, patients who have an advanced T-stage disease, and as you go through the other elements of our staging system, the nodal involvement and blood involvement, patients who have node involvement or blood involvement also have a worse prognosis. There are certain things I mentioned in my presentation that we're trying to gauge towards how do we classify and prognosticate even early stage disease, and are there certain clues that can help us in patients who have less than 10% involvement. So yes, in short, having a higher stage is a worse prognosis.
Thank you, Dr. Goto, for this insightful answer. And the other question, the second question that we have is, other than skin thinning, are there other side effects of long-term use of corticosteroids?
I can answer that as well. I want to just preface the question. So other than skin thinning, are there side effects with topical corticosteroid use? My answer to a lot of patients about skin thinning is that if they have active inflammatory skin disease, they need to treat that with topical treatments, and not to be afraid to treat active disease appropriately. I think very often patients and pharmacists and sometimes even family physicians are nervous about using topical corticosteroids long term. But in cutaneous lymphoma, atrophy is actually a result of the disease more often than it is a result of, or skin thinning is what I mean by atrophy, is a result of the disease more often than it is a result of the topical corticosteroid. Other side effects that can come with topical corticosteroid are pretty minimal. If somebody has an open infection or an ulcer, using a topical corticosteroid there might actually predispose them to worsening of infection or secondary infection. And topical corticosteroid can sometimes cause more prominent blood vessels or telangiectasia as well. But for the most part, I think patients undertreat their disease with topical corticosteroid, meaning they don't use enough.
So we have another question, which is, I'll have it here. How are the redness and itching managed after receiving phototherapy?
Another great question, thank you. Redness and itching are common after the first few sessions with phototherapy. The goal after you have a treatment of phototherapy is what we call minimal perceptible redness or erythema, meaning for about 24 hours after your phototherapy session, your skin should be minimally pink. You should not burn, and you should not be pink beyond 24 hours after your session. That's the target sort of dose and energy that we're hoping to achieve. And to manage that sort of itch that you get from phototherapy, mostly related to dryness, I suggest daily bathing in lukewarm water for 5 or 10 minutes in a bath or a shower. And then when you get out of the bath, don't dry yourself thoroughly, just pat yourself dry. You can leave yourself wet and then apply a very thick cream or ointment based moisturizer, one that you have to like scoop out of a jar, not one that comes from a pump or a squeeze, and lather it all over your body. Some of the brands of moisturizers that I like are CeraVe or Cetaphil, and that helps sort of restore the epidermal barrier following phototherapy. I will just say before I close that most patients who have itching and redness initially with phototherapy go on to do just fine without worsening of their itch, but rather improvement of their disease.
Thank you, Dr. Jory, for providing a clear and informative response to this question. Next question we have is, how do treatment options vary if you are ALP positive or ALP negative for systematic anaplastic large cell lymphoma? Let me type this question.
I missed the first part of that.
Sure. Let me put the question in the chat.
I think it's about ALK1 positive and negative for anaplastic large cell lymphoma, if I understood correctly.
Yeah.
What
While Jumana is just typing in there, I just
sure.
want to welcome Dr. Street to the webinar, who has joined us as well.
Thank you, Dr. Hardin, for addressing the questions so far, and apologies for joining a bit late, just some technical challenges connecting.
Thank you for joining us.
Nice to Okay, back to the question. How do treatment options vary if you're ALK negative or positive? Good question. So under the umbrella of systemic anaplastic large cell lymphoma, there's two subtypes, ALK negative and ALK positive. ALK positive means that their ALK protein is positive on immunohistochemistry that pathologists do. The treatment actually is the same now, at least the frontline therapy. We use CHP, cyclophosphamide, doxorubicin, and prednisone, along with brentuximab vedotin. So that was based on the phase 3 Echelon 2 study, and both of those subtypes were included. I would say one difference is we do still consider consolidative transplant following CHEP-BV and ALK negative ALCL, but that would not be standard in ALK positive ALCL. So that's probably still one difference between the management.
Thank you. That was a comprehensive response. So another question that I see here is why it is that those with the celiac disease have a substantially increased risk of developing enteropathy associated T-cell lymphoma, EATL.
Can you put that in the chat?
Yeah,
and
sure.
While you're doing that, I can actually see some other questions related to BV that I can answer before I answer that one. Somebody was asking about whether brentuximab can be used in patients who have brain involvement. Does it cross the blood-brain barrier? That's a really good question. I think there isn't good evidence that it crosses. I haven't seen a lot of data. And so we would be looking at using a different CNS penetrant drug if there was evidence of brain and systemic lymphoma. So high-dose methotrexate, which was also mentioned, asked about in a subsequent Q&A, and similar to aggressive B-cell lymphoma, if a patient is young, we actually look at consolidative transplant with high-dose chemotherapy that penetrates the brain. Just finishing the loop on brentuximab, someone also asked, does brentuximab shrink ALCL immediately? And it is pretty quick. It's very similar to chemotherapy. In the clinical trials, they're usually checking at 8 weeks, but the truth is you're usually seeing shrinkage by the first cycle. So that's kind of similar to chemotherapy in that way. I'll loop back to the question that you asked before. So it was, why is it that those with celiac disease have a substantially increased risk of developing enteropathy type T-cell lymphoma or EDOL? That's a good question. I think it's theorized that it's related to that chronic inflammation that can occur with celiac disease, and oligoclonal abnormal T cells can grow out, and they can actually see an earlier phase before frank EDOL in some patients with refractory sprue. But it is definitely been etiologically linked to celiac disease.
I would just chime in as also a lymphoma treater about the enteropathy associated T-cell lymphoma, just for people to be aware that there is a subtype that isn't associated with celiac. So we've now sort of discriminated the two subtypes of enteropathy associated T-cell lymphoma, just for our viewers' audience.
Thank you so much for your input. And another question here is, how long does treatment usually persist when patients are treated with methotrexate? I'll type the question also here.
I'm sorry, Leslie, if you heard that question, you can start the answer. I missed it.
Sure. I think the question, Jumana, that I heard was, for those patients who are treated with methotrexate, how long typically do we use the methotrexate?
Right.
So I would think that the context of this question probably would be speaking about the use of methotrexate in cutaneous lymphoma. So that's what I'll address it to be. So I guess I'd first talk a little bit about, well, when do we use methotrexate for individuals with cutaneous lymphoma? I would say that there's a small proportion of patients that we find methotrexate as a single-use agent as being a particularly helpful or therapeutic strategy for cutaneous lymphoma. There are a couple of subsets that it's quite useful for. One of them is you could consider a subtype of patients with mycosis fungoides may have a condition called lymphomatoid papulosis. That's a skin condition where individuals might have recurring crops of papules or nodules in their skin that come and go. Sometimes they occur in places on the body that perhaps are cosmetically a greater concern, or perhaps they persist longer than they would normally and haven't spontaneously disappeared. And so methotrexate can be useful in that situation. In those scenarios where someone is gaining benefit from methotrexate to control, say, lymphomatoid papulosis, we would use it for long term. What we do is give oral or subcutaneous methotrexate once weekly. It's quite similar to the dosing strategy that's used for individuals with rheumatoid arthritis or other autoimmune conditions. We're very mindful at monitoring a couple of laboratory testing, one of which is keeping track of blood counts very closely, as well as liver enzymes. And in the practice which I share with Dr. Hardin, we're very careful to assess individuals' liver health because we well recognize the associated risk of long-term methotrexate use on liver health. And so we work actually quite closely with one of our local hepatologists to monitor individuals using a specialized form of ultrasound to ensure that there's not any ill effects on the liver that's occurring with methotrexate. So sometimes that duration of time may be truncated to a period of 1 or 2 years for reasons of liver health.
Thank you so much. We have another question also regarding another treatment or medicine, which is why was there a global discontinuation of interferon alpha 2A, as Dr. Steve mentioned, as you mentioned, if it has a remarkable response in over half of patients?
Yeah, you know, this has been an interesting experience of ours. So the best that I understand, having not spoken directly with the original manufacturers that we're still making and distributing this product, is really the long history of interferon. So this agent goes back to clinical use in a lot of different conditions, including hepatitis C, even malignant melanoma many years ago. And because there's been other more effective strategies for both of those conditions, I think it boils down to probably supply and demand and use and a business decision, that there was a relatively small proportion of patients still using interferon. And I can only speculate that that may have come into play in the business decision to discontinue this. Thankfully, the product that I was referencing to was the previous formulation of interferon that actually was a subcutaneous injection administered 3 times a week. Thankfully, we still have pegylated interferon, which is available on a once-weekly basis. So we worked to transition all of our patients who were on the original formulation of interferon to the longer acting formulation, and developed a dosing algorithm to transition our patients who were stabilized on regular interferon to the long acting. And it's gone quite smoothly, and we find it equally effective. So we just hope that the makers of that particular formulation continue to see the usefulness it has for our patients. It still does have other clinical applications in various other hematology cancers that also are managed by myself and many of our colleagues, including unique circumstances for myeloproliferative neoplasms in special circumstances. So we hope that that long-acting formulation will still be made.
Thank you so much, Dr. Street. That was a comprehensive answer. So we have another question, which is if we can talk more or elaborate on mutational analysis, what it entails and the potential for this to help in diagnosis and treatment.
Is that directed at for peripheral T-cell lymphoma?
I believe maybe you can help us. Yeah.
I'll take sure if that's directed, but I mentioned it in the context of this specific group of peripheral T-cell lymphomas called T follicular helper lymphomas. So it can be helpful to have mutation analysis as they have typical mutations. And I think in the future, it'll be helpful for cases that may be borderline by pathological staining. If they have the typical mutation profile, it does actually guide the way we pick therapies for a patient. But right now, I think across Canada, the access to do routine mutations is still limited. I can say that in BC, I'm told that we'll be able to roll out a panel probably in 2024 that we would use across all lymphomas, and that can help inform. But I actually don't know in Calgary whether you guys are doing any type of targeted mutation analysis in peripheral T-cell lymphomas or other lymphomas.
Not as yet, although exciting to hear that that might be going live in our neighboring province. So we'll stay tuned. I know our colleagues in molecular hematology are working hard to work towards essentially precision medicine is what we're talking about, to use a knowledge of the pathology that an individual may have to direct therapeutic decisions. So I think we're going to see a lot of changes in the coming years, and it sounds like sooner rather than later.
And I'll just elaborate on how does it inform in treatment. we're learning in peripheral T-cell lymphomas that the word we use is heterogeneous, and there's 30 different diseases, and one size fits all doesn't work. And for the T follicular helper lymphomas, and the one people are most familiar with is called angioimmunoblastic T-cell lymphoma, there's now cumulative evidence that there's a higher sensitivity to a group of drugs, and we call them epigenetic modifiers. And they're drugs like histone deacetylase inhibitors, so romidepsin, which we used to have, but we don't anymore. There's drugs in clinical trials that we'll be hearing more about, EZH2 inhibitors, hypomethylating agents like azacitidine. That is a drug we might be able to get in a case-by-case basis. But it's clear that the response rate with those types of drugs is much higher in that group of T follicular lymphoma. So it allows us to be a little bit smarter about picking things if we can, rather than just sort of agnostic or chemotherapy where it's more non-selective. And there are other examples of that like that. I didn't have time to go into all of the T-cell lymphomas, but there's a rare subtype called extranodal NK T-cell lymphoma that we see more in Asian populations. And so in BC, we have a greater Asian population, so we probably see this a little bit more than other parts of Canada. And that's a T-cell lymphoma that has high expression of PDL, which is programmed death ligand, and is highly responsive to PD-1 inhibitors. And that's a class of drugs we use in Hodgkin's lymphoma, but there's pockets in PTCL where there might be a rational use of that. But it's still kind of on the fringe, but we are using biology to guide treatment decisions.
Thank you so much for this response. The next question that we received is, what do you recommend for patients who has had discontinued ventricular due to prolonged neutropenia?
I didn't catch that. That one was for me.
Yeah, I typed that question in the chat.
I have a guess that perhaps, Dr. Savage, this question might have been meant to be directed to an earlier CLL talks. Is the questions related to venetoclax and obinutuzumab, which is one of the combination regimes that we use for individuals with chronic lymphocytic leukemia as an upfront treatment alternative. It's a very good treatment choice for many patients with CLL, both younger and older individuals, and has become an evolving favorite for our CLL treaters. And so this is a specific management question about the tricky nuances of managing neutropenia, which can be from the venetoclax itself. So I don't know if it falls within the context of our Q&A session today.
Sure.
Or in this time block.
Sure. Thank you. Next question we received is, would you use high-dose methotrexate for an ALCL trauma on the brain? This actually resulted in the swelling of the brain that put the patient in coma as they were unable to wake up.
That's a very difficult question without sort of being directly involved, because sometimes the decisions to use these treatments is also dependent on patient fitness. But in somebody who's up and about and not significantly affected, we certainly would try high-dose methotrexate. It also depends on age as well. It's pretty hard on the kidneys, and so we can't use it in older patients and with kidney dysfunction. So I think it would probably be on the table, but it would be hard for me to say without being directly involved whether it would be appropriate in this particular patient.
Yeah, thank you so much. I believe we covered most of the questions, and we were about to conclude our session, and I would like to thank our expert, Dr. Gordy Harden, Dr. Carrie Savage, and Dr. Rosalie Strieve. Thank you so much for joining us today. Thank you for taking the time to participate in today's conference session and answer and provide us with your expertise. We hope those watching today learned something new about their and their loved ones' lymphoma subtypes. Please tune into the closing remarks in the auditorium starting in a few minutes. Thank you so much and have a good day.
Thank you.
Thank you.
Thank you. Bye.
Thanks.